What's up, guys? It's Dr. Tim Jackson with another episode of the Boss Body Podcast. Circadian rhythm, circadian entrainment. We've talked about it before. We're going to talk about it some more because I want to make sure you guys realize how important it is. So I brought in endocrinologist Dr. Kelsey Dexter.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Southern Belle Extraordinaire. Welcome to the show, Dr. Dexter.
Thanks for having me, Dr. Tim.
All right. So mitochondria. How long have you been focusing on the mitochondria? Because I know you learned a lot about it in your endocrinology residency.
Yeah, right. No, so I came into like this mitochondriac world about 3 years ago when I was suffering with my own health issues, which I think a lot of practitioners have that story, but I had been living a very poor circadian health lifestyle for at least a decade and a half, being in medical school, medical training, fellowship, answering a pager all hours of the day and night. Then went from that to, having 2 small kids and having no sleep in the setting of also never getting sun, because I was trained in Western medicine to be very sun avoidant because it causes cancer, right? Quote unquote. And that resulted in me having some kind of crazy neurologic symptoms, weird flushing heat in my foot, numbness in my toe, in my left foot, shooting pain in my face. And when I went to my local doctor, already kind of having an idea of what was happening to me with my own education background, he said, well, you're in your mid-30s and you are having these neurologic symptoms that are kind of bizarre, and this really sounds like MS. Do you want to go ahead and do your MRI and see if we see any lesions? And I said, no, thank you. Please don't put that in my chart. And I'm going to figure out a way around this. I'm going to figure out what the problem is. And so it led me down this rabbit hole of studying light, because you can see in the prevalence or incidence of multiple sclerosis is low at the equator, and it's higher the further away you get from the equator. And I thought about this lifelong sun avoidance that I'd been dealing with. And so that's what I tackled first. And I started an intentional sun practice where I sat out in the morning for, 10 or 15 minutes. And I was already really health minded. I was interested in ketosis cycling for inflammatory benefits and nutrition, but that was not moving the needle for me at all.
Right.
And so when I started getting intentional full spectrum sunlight, my symptoms went away within 3 weeks.
Yeah.
And I knew that I had discovered something important, and I knew that I had to unlearn a lot of things and sort of figure out these foundational health practices and what we're all doing to ourselves when it comes to light environment.
Right.
And then I started, I learned of Jack Kruse, and I started learning more about magnetism and structured water in our bodies and our mitochondria. And it's been this crazy journey of indoctrinating myself effectively, and learning what it really means to be healthy.
Yeah, well, that's a great story. I mean, it just goes to show you the power of nature. There's a great quote in, I think it's the first Rocky movie, where he's talking to Mickey, his trainer, and he goes, "Nature is smarter than man thinks." And I think that's kind of the basis of everything that you just really described. And so I tell people, one of my mentors is a second generation MD, and he said, you know, there's a lot of things I could teach you, but if you don't remember anything, just remember outside of trauma care, emergency medicine, stay the hell away from. Excuse me, Marcel, can you edit that out? Sorry about that. Stay the heck away from traditional medicine. And he was right. Surgeons, when in doubt, cut it out. Every case is a surgical case. So I tell people, okay, ask before you go to any sort of doctor or healthcare provider, ask what they have to offer.
Mhm.
Because if, surgeon, it's going to be cortisone shot or surgery, right? And, that's what happened to me. Like everything that I had going on with my jaw, well, first of all, it wasn't as serious as they said. But they told me, hey, you're not going to have any teeth left by the time you're 30 if you don't have this surgery. So I was 20 or just turned 21, it scares you. And so I'm like, oh, well, I got to get this surgery done. But now I know all could have been fixed with a palate expander. But, that's a couple grand compared to, 60 grand or whatever the surgeon was paid to do the oral surgery. So, I mean, I think we have to take a step back and look at, are we harming people? And, there's benign neglect. A lot of times people generally think they're doing well with, prescribing 18 medications or 12 medications, and sometimes medications are needed. But cellular biology, cell molecular biology, my professor at Wake Forest for cell molecular biology, he was in medical school. And he was like, I want to learn more about like mitochondrial health and the plastic reticulum. And so he told me he was going to drop out of medical school. So they referred him to a psychiatrist, and he's like, I'm not depressed. I'm fine. I just think this is BS. Respectfully, this is BS. And so he's got his PhD in cell molecular biology, but I go back to those principles all the time because the mitochondria, they're not just in the batteries of the cell, they're an entire signaling system, right?
Right. Yeah. Um, and I hear you. I respect physicians deeply. And there's an initiation there that is pretty intense, and people that make it through, um, I applaud them. But our current healthcare system is so steeped in pathology and pharmacology. And if you have a chronic illness, you're really rarely going to find healing in the form of a medication without addressing mitochondrial health, circadian health, foundational health.
Right.
So that's really the message I try to get to patients. And um, we have a lot of work to do,
Yeah.
obviously, in educating the public and other practitioners. So,
Right. Well, I mean, even within endocrinology, so I had another endocrinologist on, Dr. Cassie Smith, and she said, she did everything she was taught in residency and fellowship. People were coming back. Not only were they not getting better, they were getting worse. And every 6 to 12 months, they had to add a medication. She's like, there's got to be a better way. So she started doing functional medicine, and she was getting great results. The problem is she was renting space from the previous endocrinology group she was a part of, and they wouldn't renew her lease. So she had to, luckily, one of her patients was a contractor, and he was helping her, build her office building. And so they expedited it, and she was able to open on time. But even with something like free T3, like endocrinologists typically freak out. Can you talk about that and TSH and thyroid hormones?
endocrinologists freak out. What do you mean?
Well, so they don't like to prescribe T3 only.
Oh,
They don't even like to prescribe T4, T3 combos. It's just like, here's T4, you can convert to T3. They rarely check, in my experience, thyroid antibodies, which are extremely important. So, yeah.
yeah. I I trained at University of Colorado, and it's one of the biggest thyroid centers in the country, and the guidelines come out of that particular institution.
Right.
And there was a lot of discussion about this in my fellowship training, but um, I definitely have a different approach than the standard endocrinologist does about thyroid testing. I think, we have two different issues when it comes to thyroid disturbance. You can have autoimmune signals, which
Right.
are picked up by checking the antibodies. And then you can have overt hormonal dysfunction, which is picked up by looking at a full thyroid hormone panel. And there is some data that, especially in people who've had their thyroids removed, doing combination therapy with T3 has a pretty impressive symptomatic benefit. So, I think, well, I like to think about normal physiology, right? So a thyroid makes mostly T4, but it makes a little bit of T3 in about a 12-to-1 ratio. And so whenever I am supplementing thyroid hormone in someone who makes very little or none, I try to mimic that ratio as closely as possible as the first step to see if that particular formulation combo is going to make them feel better, right? And if it doesn't, we move on. So
Right.
I don't do solo T3 because I don't really believe that that's physiologic for the body. That doesn't mean that people couldn't do well on that, but I've seen a few patients on high dose T3 solo therapy from other providers over the years who have a TSH of 0, a toxic T3 level, well, above the reference range by double, okay, and then like no T4. And they feel fine. They feel good. And they're not having atrial fibrillation. I don't know about bones because I probably didn't do a DEXA scan on them, but those are the things that I worry about with chronic TSH suppression, But my goal when I'm working with somebody with thyroid issues is to mitigate symptoms, help them feel the best they can, and keep them safe at the same time.
Yeah.
Overdosing thyroid hormone is a problem in a lot of integrative practices. I mean, I've seen this. I've had patients come to me from another practitioner who were on really high doses of T3 or Armor, et cetera, and were like vibrating on my exam table. Several symptoms of thyroid storm, ongoing liver dysfunction. I've seen this happen. And so I think we have to be careful with hormone replacement because it's not innocuous, right? It's like you have to have some restraint, go low and slow, and it's fine to try different formulations, but we keep patients safe first and foremost.
Yeah, and not only that, I used to work with a nurse practitioner in North Carolina, and she would have patients on up to 4 grains of Armor thyroid, and she never checked cortisol. The reason they weren't responding in the first place to even a little bit of Armor is because cortisol is tanked. And so, you got to work on the HPA axis. Obviously, cortisol and thyroid work together, and you won't need as much thyroid replacement. And then, everything's a cascade, right? Like you got to look at insulin levels, fasting insulin, hemoglobin A1C, all of those markers for insulin resistance and insulin sensitivity. But yeah, I had people coming in with AFib, they were on way too much Armor. And I'm like, let's check your cortisol. It's basically 0. And, get them on some adrenal supplements, some adaptogenic herbs to mitigate the HPA axis. And, they start feeling better and they can go down to, 1 grain or half a grain or maybe no thyroid.
Mm-hmm.
The other thing I like for thyroid is red light therapy, red and near
Oh,
red light.
yeah. Mm-hmm.
Yeah.
I utilize that a lot in patients who have autoimmune thyroid disease.
Yeah.
It's been shown that red light therapy decreases thyroid antibodies. But what can't red light therapy do?
Right.
It's so beneficial for the body, and it's free from the sun. So, yeah, I work with a specific torch that I really like. I mean, all of them are probably fine, but we do a 3-minute.
Light path.
No, I like Solil Well. That's the one I've used the most. Kelly Bento's products. They're very, very excellent. But yeah, the protocol that I use is 3 minutes twice a day, right against the thyroid during daylight
You say
hours.
3 or 30?
3.
Okay.
Yeah, 3.
Right.
Um,
That's good.
yeah, her torch is very, very potent, and you can definitely overdo red light therapy, right? When you have that close contact and that degree of lux. So yeah. But I use that in my protocol to reverse Hashimoto's. That's a big part, is using therapy. Yeah.
Absolutely. I mean, I don't know if you've read Dadis Karazian's book, Why Do I Still Have Thyroid Symptoms When My Lab Tests Are Normal? Have you heard that? So it's a great book. He's got 3 doctorates. He's a chiropractor. He's got a PhD, a doctorate in health sciences. He's on faculty at Harvard. But it's a great book with a lot of references. But he talks about Yersinia, pathogen in the gut, can induce thyroid autoimmunity, Epstein-Barr, mycotoxins, Lyme, Bartonella, really any pathogen, right? But yeah, the foundational health principles, grounding, mitigating EMFs, calcium efflux that comes from that, peroxynitrite. And then obviously that's going to cause alterations. I know in the form you filled out for the podcast, you talked about, dysglycemia and eating the same food in a low EMF environment versus a high EMF environment. You're going to have hyperinsulinemia in the high EMF environment, correct?
Right. Your light environment makes a difference there too, right? They've shown that in healthy volunteers, if you do a glucose tolerance test and you give the glucose under red light versus blue light, same participants, same dose, same time of day, etc., you get a 27% reduction in the glucose excursion under red light as opposed to blue light. And I want to circle back to something that you said about, like, why do I feel terrible when my thyroid levels are normal, right? And I think a lot of times it's not thyroid. So I do a lot of work in leptin resistance too. And, so leptin is a hormone made by adipose tissue, by fat cells, that signals to the brain the energy storage load of the body, right? And over time, if you are blue light toxic, if you are chronically stressed, if you have high leptin levels for a long time, the brain gets resistant to the leptin signal and it no longer recognizes that the body has all these energy stores. So what's supposed to happen in, from a survival standpoint is if body fat gets really, really low and leptin drops to 0, then the metabolism is downregulated. And part of that occurs through thyroid hormone conversion, right? So you stop converting to active thyroid hormone, T3 levels fall, you convert T3 to reverse T3 to inactivate in the bloodstream. So you have a functional hypothyroidism whenever the metabolism is tanked due to low leptin. Well, that can happen in leptin resistance too. So if the body can't see its own energy stores, then it downregulates these energetic pathways to decrease the metabolic rate. And so I see all the time patients come in who have their hair falling out, irregular periods, cold all the time, can't lose weight, fatigued, and they say there must be something wrong with my thyroid. And I do a huge thyroid panel and it's perfect. And I check leptin and it's so high. And so I really think that, sometimes in those thyroid panels, I can see a high reverse T3. That's the other sign that leptin resistance is probably an issue. But when I start to work on leptin, all of those symptoms improve and thyroid hormone conversion kind of picks up, metabolic health improves. That's one area. And the other side, I have people who have really profound thyroid autoimmunity, like their inflammatory markers are so high and their thyroid levels are normal. So when you go to a standard conventionally trained endocrinologist and you walk in for a thyroid exam and the thyroid levels, TSH, free T4, free T3 are all perfect, you're not going to get thyroid hormone. And that is the tool. That's what we have to offer, right? This is what you talked about earlier. Like when you go to a practitioner, you ask them, what do you have to offer me? Well, in the world of thyroid, you get thyroid hormone, you get anti-thyroid medication effectively, unless you have a nodule, then you get a biopsy, right? But in general, most endocrinologists don't do anything about thyroid hormone, thyroid antibody elevation. And like you said, I know that many don't even check it because they just assume that they'll be high, because the most common cause of hypothyroidism in this country is Hashimoto's, right?
Right.
Um, but there's plenty that we could work on to help the thyroid autoimmune response. And um, having Hashimoto's doesn't mean so. Okay, a lot of endocrinologists would say, if you have the antibodies, you're probably going to progress to hypothyroidism eventually, and it doesn't have to be a progressive disease, because I mean, I know tons of people that have reversed their thyroid autoimmunity. So I think collectively we need to be paying more attention to these early disease states,
Yeah.
and trying to improve health to support resolution. But I typically lean heavily on circadian regulation, grounding practices, red light therapy. There's data that using selenium and inositol in combination can help lower thyroid antibodies compared to placebo. Sometimes I work with adaptogens like ashwagandha that also can, kind of speed up thyroid hormone production in the body, for functional benefit, just symptomatic benefit, and to support the HPA axis. But yeah, there's a lot.
Yeah. And I mean, ashwagandha, I use it sometimes, but if someone's on thyroid medication, I give them ashwagandha. It floods the cell, or it can flood the cell with T3. It's going to escort it so they can go hyper if they're on thyroid medication. So usually the dose, you'll have to titrate it down.
I don't give it to anyone who is hyperthyroid, obviously. But and most of the patients that I've had it are not on any thyroid hormone supplementation. They're just antibody positive, and we're trying, and a little bit hypothyroid,
Yeah. Well, and the other thing I see in functional integrated medicine is someone will have elevated TPO and antithyroid globulin antibodies, and they'll get prescribed T4 or T4 T3 combo. But you're trying to treat an immune system issue with hormones, and you're not addressing the immune, the Th1, Th2, Th17 imbalances. And so, I mean, functional medicine, we like to use low dose naltrexone that can help drop the antibodies. I take it prophylactically, just because it raises natural killer cell levels. But addressing viral load, pathogen load, mycotoxins, gut pathogens, and you see the antibodies go. But the other thing is, even when someone does need thyroid medication, I see endocrinologists freaking out. Your TSH is 0.3 or whatever. I'm like, it's a brain hormone. It's not even a thyroid hormone. It's an anterior pituitary hormone. But I also know endocrinologists who started out the conventional route and then, graduated over to functional medicine. For example, there's something called Dennis-Robertson syndrome. It's named after two MDs in Atlanta, and one is David Robertson, who's an endocrinologist. But when mold colonizes the paranasal sinuses, it can cause a basically relatively permanent lowering of growth hormone. But if you look in the textbook of endocrinology from like the 80s, it says 50% of people with low or normal IGF-1 actually have low growth hormone. So you have to do a glucagon stimulation test, which takes several hours. Usually have to go into a facility. But I take 1 milligram of growth hormone at night because I had mold exposure in the past. And my growth hormone levels were low, and that was despite doing all the circadian rhythm things, resistance training, molecular hydrogen, red light therapy, sauna, vibration plate. And so it's not a bodybuilding dose. I didn't gain any muscle from it. It helped improve my sleep quality. And, if you look at the thymus gland of people who start growth hormone, it doubles in size after a year. And there was a trial called the TRIM trial. It's an acronym for thymic rejuvenation and insulin mitigation. So they worked on rejuvenating the thymus gland and mitigating insulin sensitivity or insulin resistance, improving insulin sensitivity. And they were able to reverse biological age by like 5 years, I think.
Interesting. You got a lot of stuff going on, Dr. Jackson. I don't know how you keep up with all this biohacking.
I just kept learning and learning and learning some more. And I mean, I got enough equipment in here to start like a membership. I could put a little thing on the front door where people just scan a card and come in for some red light therapy and some molecular hydrogen.
Yeah. Come see you for a spa day one day.
Yeah, exactly. A spa day. I just need someone to do. Well, I'm not a big proponent of like the fillers. No offense if you're doing fillers, like calm down. It's okay. But I know a guy, Dr. Mark Galey, who's a DO in Los Angeles, and he treats people who've been injured by fillers. Like you can develop a tremor. I mean, I thought if it had the word toxin in the name, maybe that would be a clue to people that it's probably not a good idea to inject it. But I assume things wrongly sometimes. So
I've kind of come full circle on that over the course of my adult life too. Because I used to be a fan of Botox. I had filler one time and it was awful, and I would never do that again. But when you work so hard to detox your body and to be as healthy as possible, like why do you want to put toxin back in intentionally in any form? So anyway, new focus. But
yeah,
I think there's a deeper issue of women in particular, but it's pervasive in our culture that we like try to hang on to youth, right? And it's very prevalent in the biohacking community as well. Biological age
right.
more than physical age. But I really wish that collectively we could just like ourselves more and like accept aging as a privilege.
Yeah,
And yeah, we're all lucky to get older, lucky to get
yeah,
wiser. And it's okay if that shows up on our faces a bit.
yeah. I'm totally fine with that. I just don't want to be decrepit,
Yeah.
when I'm 70 or 80. Like I want to be deadlifting 400 pounds still. Like I want to be performing at the highest level. I saw a video a couple months ago, like this 96-year-old lady deadlifting like 1.5 times her body weight, which is impressive.
Mhm.
So I mean, I think yeah, it's fine to get older, but getting older and getting decrepit are two different things.
Oh, yeah. Just because something is common doesn't mean it's normal, right? I think
I
about
say that all the time, yeah. Because
yeah.
people normally say, "Oh, well, that's normal because Sally Joe down the street, she has 3 autoimmune diagnoses. She has 2 types of cancer." And I'm like, normal is Homer Simpson. You don't want to be Homer Simpson. Um, when people say something's normal, they really mean it's common. But we have
Mhm.
to stop normalizing pathology, you know?
Agree, 100%. Um, Patients come into my office every day and they say, "Well, I'm tired all the time, but it's just because I'm getting older, or my hair is a lot thinner now, but that just comes with age." And I'm like, "Well, actually, no, it doesn't. It doesn't. Our society, it's a common thing you see, but that's not normal. Like it's perfectly normal to be vital
Right.
into old age. So yeah, I'm ready for that to be more emphasized, normalized,
Yeah.
but we have to be the example, I suppose.
Yeah.
Yeah.
Absolutely. Talk to us about insulin resistance. Well, we talked about leptin resistance, but insulin resistance, I know you're a big fan of metformin. Stick.
Ah!
Um, Actually, I don't like metformin. Well, before you answer the question, I'll just say I don't like metformin for a number of reasons. One, it blunts the effects of resistance training and exercise. But number two, it blocks the methylation pathways,
Mhm.
MTHFR, the whole methylation cycle. And you can achieve the same thing if you need something with dihydroberberine, which is 5 times more bioavailable than berberine. And it's like $15 per month supply. And it's not going to block the effects of exercise, but you also, get outside, you ground, you get sunlight, you do some resistance training, upregulate your GLUT4 receptors. What say you?
Well, I like that little intro.
Yeah,
I would agree with you about the metformin. I use a lot of berberine. I don't know about, did you say dihydroberberine?
yeah,
So
it's 5 times more bioavailable.
I'm an herbalist, and so I work with berberine a lot in its native form, and Oregon grapefruit and golden seal and bayberry and these herbs. And so it comes from the roots of these these plants. They have yellow roots when you pull them out of the ground. Berberine has that pigment, which is really cool. So I work with it a lot that way too. Um, I love holistic medicine. And so whenever you start taking a compound and distilling it down to the most active thing sometimes that's good because you get the most action, right? But sometimes bad because that comes with the most side effects. So, but anyway, I'm excited to learn about that because I hadn't heard of that before. Well, insulin resistance is exceedingly common, right? I like to say that the American lifestyle pretty much just gives you that. Like if you live like this, the average American, you will have metabolic dysfunction as evidenced by either overt or relative insulin resistance. And we know that 93% of Americans have metabolic dysfunction, right? So this is a big issue. And insulin is a growth hormone, and it is a growth and storage hormone. So when insulin levels are high all the time, which is a hallmark of most insulin resistance, right? Your body really can't get into deep repair and restorative states. And, you know, we in the, what am I going to say? Common, not normal. I'm trying to watch my words here. In the common American life, we gather plaque in our arteries, we gather tau proteins in the brain, we gather abnormal cells that are precancerous or cancerous. And if you don't have pathways to eliminate those, and they are constantly getting your body's constantly getting a growth signal, then all of these chronic diseases associated, cardiovascular disease, Alzheimer's, cancer, skyrocket, right? With this insulin resistance association. So most chronic diseases that Americans die from are directly linked to insulin resistance.
Right.
And our ancestors, you know, had periods of lack, of starvation. There would be seasons where there were no carbs available, say for like a few root vegetables maybe in the winter.
Right.
And so every winter when we were cold, which also has metabolic benefit, we would be in ketosis or fat burn. And that level of that breakdown state, that catabolic state, allows our body to get rid of what it doesn't need, to clean up tissue, promotes new stem cell growth. And so in our modern world, we have to have some kind of scarcity inserted into our modern lives to make sure that our body can enter that state. That's my opinion anyway. So that could look like local seasonal eating and seasonal ketosis. That could look like ketosis cycling, where there are periods of low carb eating to let insulin levels fall. I really think that promoting metabolic flexibility is should be the main goal, meaning that our body can flip between fuel sources easily. So if insulin levels are high, the body really can't mobilize fatty acids from fat stores for fuel. So like being able to suppress your insulin level, especially overnight while we sleep, to promote loss of old fat stores, mobilization fat, and this repair and restore, you know, sequence in the body is important. And I do a lot of coaching on that with patients in the office who are interested. Again, insulin resistance causes mitochondria dysfunction over time. So cellular energy level drops. And this is another reason why people feel tired all the time and they can't lose weight when their insulin levels are high. The insulin and leptin kind of track together in this way, especially in women. But yeah, it's a primary focus of my care as a practitioner. Mm-hmm.
And so if someone needs some supplementation to improve insulin resistance, or insulin sensitivity, there's chromium picolinate, there's berberine, anything else that you use, alpha lipoic acid?
Mm-hmm. Yeah, alpha lipoic acid. Those are probably my three most common. Yeah, I don't lean heavily on supplements. I think that first of all, eliminating as much processed food as possible, right? I pick on grains, processed grains, and sugar a lot because, you know, 60% of the American diet is processed grains. And that if you've done much personal experimentation with continuous glucose monitors, even in a metabolically healthy person like me, that stuff makes my blood sugar go insane, right? So nobody really should be eating it. So if we, from a food standpoint, if we can start there and increase protein, fat, and fiber, decrease processed grains. That's where we start. I then talk about meal timing a lot because a lot of Americans love to skip breakfast, and that's not good for metabolic health. There have been studies that show, well, this is PCOS population of females, but if you give them the same amount of calories in a day, but you give most of them in the morning versus most of them in the evening, metabolic markers improve dramatically over time. So I like to talk to all patients about eating a high protein, moderate fat, very low carb breakfast with regularity, and then trying to restrict their eating window to 12 hours or less during the day. So we work a little bit on chronobiology there. You know, we know the body is, it's more insulin sensitive in the mornings. We tolerate food better in the day when we're going to be up and moving and using our muscles. So even if, let's see, yeah, food first, light also first. So I talk to everybody about the food that they take in, their junk food, their junk light, right? Because we know that there's a pathway by which isolated blue light raises blood sugar and raises insulin through cleaving POMC, this hormone that comes from the brain. So if you bathe in blue light all day and you are eating nothing, you can still have high glucose and high insulin levels. And that's where I think a lot of people don't know this light connection when it comes to metabolic health. And I see lots of patients who have been eating very clean, high protein, exercising every day, and they can't lose any weight. I've done full hormonal workups on them, right? And usually they're still moderately insulin resistant or leptin resistant, but it has most to do with their light environment, not the rest of their behavior. So I talk a lot about that. Muscle mass is very important to improving insulin sensitivity, right? Because we can store glucose in 3 places. We can store it in our liver in the form of glycogen so that our brain has glucose while we're fasting, right? We can store it in our muscles in the form of glycogen so that we can run away from a predator and that fuel is easily available. And then we can store it in fat cells. So glycogen is our short-term glucose storage. Fat cells, long-term glucose storage, and the body doesn't really like to mobilize long-term stored energy, and especially won't do that if you are not mobilizing the short-term energy and using that on a regular basis, right? So as far as the liver glycogen, the less carb you're putting into the system, and then the longer you're going without eating overnight, the more likely you are to use up that liver glycogen. So that's a potential place where you can put the next day's carbs if you ate some for storage that's not fat, right? And then the more muscle you have, the bigger storage tank you have for muscle glycogen, and we use that up really quickly. So I see, I get a lot of ads for different practitioners who are promoting their weight loss programs or whatever. I see these big men who are like 300 pounds of solid muscle, and they say, your doctor told you that you can't eat donuts and lose weight, but you can. And I'm like, yeah, you can, because you're 300 pounds of muscle and all you're doing is replacing your glycogen every day when you eat these refined carbs, right? But for a person who is profoundly insulin resistant, like any sugar is going to keep their insulin level high long term. So yeah, the way we deal with metabolic dysfunction has to be very individual depending on the hormonal state. So any activity is good. You know, there was that study, I'm really bad at remembering dates and specifics about studies I read, but they compared 10 air squats every hour to a 30-minute walk a day and improving metabolic markers, insulin sensitivity, glucose trends, and found that that was superior. So I have a school group, SKOOL, like education group, where we do these monthly challenges. And this month, that's what we're doing, is everybody's doing 10 air squats an hour during the day. Just
That's
as
awesome.
yeah. So something as simple as that, like engaging your biggest muscle groups and depleting the stored energy there on a regular basis can improve your insulin sensitivity, right? And then the other thing that I think is underemphasized is cold therapy, right? So one of the reasons that in our modern life, we have such poor metabolic health is because we live in these temperature controlled environments and our body doesn't have to generate heat.
Right.
And we can generate heat two different ways. You can shiver, so muscles contract, and that's not very efficient. Or you can engage brown fat thermogenesis, right, which is initiated by cold. And I read a study a couple years ago where they just looked at men over the age of 55. Again, you may know this better than me, Adam, because the details, but basically you can only see brown adipose tissue well on PET scan because it's metabolically active. And it sits kind of under the clavicle, under the scapula, down the torso, and makes heat from glucose in your bloodstream, triglycerides in your bloodstream, and then from stored energy when that kind of runs out. But when they just scanned all these men to look for brown fat load in the average person, nobody had any.
Right.
So that would lead me to believe that the average American does not maintain brown adipose tissue. And the body wouldn't anyway if it's not getting the signal that it needs to make heat, because brown adipose tissue is full of mitochondria and it's energetically expensive to maintain. But
Right.
when you start exposing your body to temperatures that are a little bit uncomfortable, really anything below your body temperature, especially to the point of a shiver, you stimulate production of that tissue. And then when you get cold acclimated and you can generate heat without shivering, you generate that heat from your available energy in your body. So not only does it make being in the cold much more comfortable, it improves insulin sensitivity, and it is another place for your body to use glucose through a pathway that doesn't involve insulin, right? That's the other important thing about muscles, to circle back. Like, there is an insulin independent transfer of glucose from the bloodstream into muscles. So if you can store extra carb in your muscles without stimulating this growth and storage hormone, then that's really beneficial overall. Yeah, so I really think that getting acclimated to the cold is probably a lot more accessible than these kind of aggressive strength training protocols that some people might recommend for improving insulin sensitivity. I think you can do all these things at the same time, but we're coming up on winter in the Northern Hemisphere, and it's always a really good time, if you're working on your metabolic health, to just start sitting outside in cold ambient air, getting a little bit chilly and letting your body get used to making some heat. You can progress over time to intensify that therapy. And, like, I'm a big fan of cold plunging, but not for the person who's not cold acclimated.
Right.
Starting easy and letting your body adapt is the goal for most.
Right.
But I'm a big fan of leveraging that pathway too. Yeah.
Yeah, and to circle back, you said in terms of glycogen. So like when someone's, breakfast comes from breaking your fast, but you were talking about if you eat carbs, you can potentially store the next day's carbs. I didn't catch all of it.
Oh, I just meant if your glycogen stores are empty
Uh-huh.
and you eat carbs the next day, the first place those are going to be stored is in your liver and your muscles, right? Not in fat.
Right.
Caveat, if you wake up in the morning and you've been fasting for, 16 hours or something, and you put refined carbohydrate in your stomach, glucose goes crazy high, and that probably stimulates a big insulin response. So it's probably mixed storage
Yeah.
because of the hormonal milieu. But
Right.
in general, the goal for someone to maintain metabolic flexibility would be on most days to use up their glycogen stores, right?
Right.
That really helps overall. So that involves movement and timed eating intervals.
And so you're saying consume when you're eating your carbs, complex carb versus simple carbs. That way
Absolutely.
most of it is glycogen versus spiking insulin and glucose.
Right.
Okay.
I think everyone needs to get rid of processed carbs in their diet most of the time, right? What we do most of the time is what gives us our outcomes as far as health. So, yeah, I'm a really big proponent of just getting rid of the junk food, and then it's no longer an issue. But like, I've done a lot of personal experimentation with continuous glucose monitors. I'm
Yeah.
like, I love these interval experiments, you know.
Right.
But I was very, very big into fasting protocols a few years back, to my own detriment. But maybe that's a story for another day. um, and I was doing 1 meal a day for about 6 months, and I was not choosing great food to eat during my 1 meal of the day because I was very busy and I was eating out, and um, I was starving by the time I actually ate. And so I often would go to the local Mexican restaurant where they would bring you chips right before you eat your meal. And you can't even tell them you don't want them, really. They're just going to be there.
Right.
And when you have a very hungry girl who has no body fat, right, who's like has a basket of chips in front of her, she's going to eat those chips. Yeah. So anyway, I wear a glucose monitor a lot, so I would watch my blood sugar go from like 75 to 210.
Wow.
And then I was like, wow, I have diabetes. But no, it's not that. It's that your insulin levels are suppressed after a long fast, right? So there's nothing to catch that glucose when it's coming into the bloodstream to shuttle it into storage. And instead, it builds up while the pancreas mounts its insulin response, and it can get quite high. It's a relative insulin resistance that happens when you are in fat burn for a long time and you aren't as good at handling carbs. So, anyway, physiology is really cool. But I think a lot about um, people who just eat whatever they want, right, with no insight as to how that's causing these blood sugar swings in their body. And when we have huge blood sugar rises, even if we don't have diabetes, it makes us feel really bad. It like feels terrible in the body, and often creates like fatigue, sleepiness after meals. You could have a rebound hypoglycemia in that kind of scenario because the body produces this huge push of insulin to try to get that glucose down, and it overshoots just a little bit and causes the glucose to fall quickly and dip into low territory, and that causes all the same symptoms that someone would get if their glucose was low and they were dying, right? Sympathetic activation and shaking and sweating. And so I get a lot of referrals for hypoglycemia in patients who really have this relative insulin resistance and are triggering huge insulin secretion by the stuff that they eat. It's not
Right.
always the case, but yeah. So when we cut out processed food most of the time and eat a lot, and our carbs have a lot of fiber,
Right.
that just happen. So
Right.
bodies feel better overall. Glucose levels stay more stable. You improve insulin sensitivity over time because you're not having these big insulin surges in the bloodstream. It's really important for overall health and long-term metabolic health.
Do you see people having insomnia or waking up during the middle of the night or say 2 a.m., 3 a.m. because they have reactive hypoglycemia?
Uh-huh. Yes, I do. And um, so usually in that population, they are not very good fat burners, right? So people who are metabolically flexible, whose blood sugar drops, generally can mobilize adipose and then make ketones, and it's sort of an easy transition from one fuel source to another. And when you're not fat adapted and blood sugar gets low, the body is begging for carbs, and it will trigger this fight or flight state to get you mobilized to raise that glucose. So um you know, those people generally go to carb to fix that issue because it makes them feel better instantly, so they think, well, this is what my body needed. But those folks in particular do really well when they increase protein, fat, fiber, complex carbs in the diet and eat enough to stay full. So that's really what I work on with patients that have that issue. I've seen in recent years too, because I get a lot of patients who are very health minded and they're very into hormetic stressors. People who wake up in the middle of the night because cortisol's high because they have and done so much to their body to stimulate a relative stress response for improvement. And so like that could be high intensity interval training. It could be too much caffeine. It could be fasting too much cold plunge. There are lots of reasons why it could happen, but I always make sure that we're looking at nervous system health too. Yeah.
That's the other thing I test through the DNA company. There are single nucleotide polymorphisms, but then there are copy number variants, insertions and deletions, loci, like the loci, like the physical address on your DNA. But there's one called UCP1, uncoupling protein 1, and it has to do with thermoregulatory control. So if you have the poor form of that, not always, but sometimes they don't do the best with cold plunging. But the other thing is the neurotransmitter clearance. So if you have a slow COMT enzyme and MAO monoamine oxidase, then the dopamine surge is good, but it can keep you up at night. So I'll have, instead of doing it every day, I'll say 3 days a week, and then they do much better in terms of clearing their dopamine.
Yeah, cool.
I mean, I got way too much time on my hands, clearly. Reading all this. But what's something you know today you wish you would have known? Well, how long have you been practicing? You're like right out of med,
What?
you're like right out of med school. I mean, you're like female Doogie Howser.
I'm glad you think so. No, so let's see. I've been practicing endocrinology out of fellowship for 9 or 10 years now. I graduated medical school in 2010. Yeah. So.
Okay. So what's something you know today that you wish you would have known back then?
Oh, that's easy. That sunlight is vitally important for health, right?
Oh, I thought you need to like bathe. I was going to open a car wash that instead of washing cars, we wash humans, but we spray sun protectant, sunscreen on people. I just thought, the sun was always trying to kill us. That was its main goal.
Now, it's been a very humbling journey for me because like from a very young age, I have been telling everyone I know that the sun is going to give them cancer. I mean, I wrote my senior research paper in high school on the dangers of UV light. So this was my path. This is what I was supposed to learn. I think that things happen to us for a reason.
Right.
And my journey from illness to realizing that the sun was healing is what I'm supposed to be teaching. So
Awesome.
Yeah.
So we're going to put up your links, but real quick, where can people find you?
So let's see. I'm a little bit active on Instagram. So I'm at Kelsey Dexter, MD there. I have a school group that I run with another practitioner that's called Circadian Health Revival. And so for people that want to like engage me regularly, that's a really good place to do it. We stay pretty active there. I see patients at 2 different locations in Tennessee, but I'm licensed in Tennessee. So for now, I have to stick to people who are in Tennessee. And I have information about that on my Instagram too, through my link. Yeah.
Awesome. Well, thanks for the work that you're doing, and hopefully we can have you back on in the future for an update if you're not outside getting a suntan.
Well, that's what I do in all my spare time, which is limited, but still, that's the priority.
That's all right. You seem to be doing a great job.
Thank you so much. I appreciate you.
All right. Have a blessed day.
Thank you.